I'm your moderator tonight. I'm Beth Emery. I'm a 15-year survivor of stage 3 HER2-positive breast cancer, a past president of the Alamo Breast Cancer Foundation. I'm ABCF's alternate to the National Breast Cancer Coalition Board, and I'm also the Texas field coordinator for NBCC. So if you're ready to lobby, talk to me. I want to thank all of our volunteers, without whom we would have been unable to put this program together. And that's the men and women who are personing the booth downstairs, handling all of the local logistics here, helped us with our great welcome dinner, and are helping us put all of the programs together. Most importantly, we want to thank our sponsors, and they're listed up on the slides. We are so blessed to have the financial support of these organizations. They make a huge difference for us. They're the reason we can put together this program. And more importantly, as we have developed since COVID, able to provide it in a way that it's accessible to 600 registrants who will be looking at one or more of these programs online in someplace other than San Antonio. I will, before we have tonight's mentors introduce themselves, I have a few housekeeping items. One, put your phones on stun. We don't want anyone to ring. And I did that because it plays my college fight song. It's very embarrassing when it goes off. The mentors will start with a brief 10-minute discussion of what they think was one of the most important things that happened yesterday and today, and then we'll have time for audience questions. When you come up to the microphone, which you must do so that we can record it and use it in the live stream, state your name and your organization. Please hold to a single question unless you're the last person in line. Understand that we want you to talk about general questions, not your own personal situation. It's important that we do that so that we keep it at something that everyone can benefit. And we're live streaming, which means we have a hard stop. And I will give a warning, but I think I'm a lawyer, and it's sort of like the Supreme Court. You can be stuck in the middle of saying the word A. So we will stop, and I will give us a little bit of time so that I can do a final wrap-up. Please, please, please fill out your evaluation form. There are hard copies on the tables, or you can do it online. And finally, be sure to come back for the rest of our educational programs and hot topic sessions. There are trifolds out here that give you the times. Pass them out to your friends. There are 400 advocates registered for this program who are present in San Antonio. And tomorrow, we want all 400 of them to be in this room tomorrow night. So I'm going to start with each of the mentors who are going to introduce themselves. We're going to start with Dr. Virginia Borges, then Dr. Andrew Brenner, Dr. Jenny Chang, Dr. Bora Lin, and then finish with Dr. Alistair Thompson. So please start and just give us a brief description of your background.
Absolutely. So I am Dr. Virginia Borges. I go by Ginger in person, and I am a noob to this event. So thank you very much for inviting me and having me. I'm a breast medical oncologist at the University of Colorado in Denver, and I'm the head of the breast program there and deputy head of the Division of Medical Oncology and a few other titles. Do I keep going into what excited me today? No, we just introduced.
No, and
we'll, that's enough about me.
We'll let Dr. Brenner. Everyone can introduce themselves, and then we'll come back and start with you.
It's a pleasure to be with all of y'all. My name is Andrew Brenner. I'm a professor of medicine, neurology, and neurosurgery. Started off doing breast research years back and have worked a little bit into the neuro-oncology perspective, dealing a lot with brain metastases, especially as relates to breast cancer. My laboratory interest is in developing new therapies for cancer metastasized to the brain. And I am with UT Health San Antonio as well as Texas Oncology in Austin.
Thanks. Jenny?
Hi, I'm not a newbie, Ginger. Jenny Chang, Houston Neal Cancer Center. This is my favorite event of the whole session, to be honest. Never miss it. It's always so good to learn from you and to hear what your concerns and our concerns are. Maybe we can get a bar and get some advocacy going. But this really, truly is the best event for me of the whole session.
Hi, my name is Bora Lim. I'm a medical oncologist for breast. So, like the ones who are giving you toxins and all this, horrible stuff. And the bad player in the game. But I do translational research, just like any of the panels here. And, my passion is trying to develop what's happening in the bench, the bedside back. So that's what I do. And it's one of my favorite events as well. So I'm so honored to be back.
And my name's Alistair Thompson. I'm a surgeon. It's a real pleasure and privilege to be back here tonight. Thank you, Beth. Thank you, Carol and colleagues, for having me back. I guess my story is I worked in the UK for 20 or 30 years in breast surgery. I married a girl from Mississippi in 2011. So I'm told we ruined the perfect marriage by me moving from the UK to the US after 3 years, but that's not true. It's been brilliant being in Houston and currently at Baylor College of Medicine. Thank you.
That's great. Okay, Ginger, what's hot?
What is hot today? Well, I don't know if you guys had the chance to see, but we had a debate about whether or not we should still be using anthracyclines for the treatment of breast cancer, and I had to take on the estimable Martine Picard. I was given the opportunity to argue against the anthracyclines, so I think I had the easier job. We highlighted the data, both old and new, involving why these drugs have been at the forefront of how we treat breast cancer for so long, but also really delving into what are two of the most dreaded side effects that they can bring to the table: cardiac toxicity and secondary leukemia. Some of the things afoot in ways that we could identify folks who might be at an increased risk of having these toxicities if they need to take the medication based on today's best science. And also explored the subsets, ER positive, low risk, triple negative, what we do for our older women, women who may have other medical issues that put them at increased risk, and of course the HER2 positive space, and where we can really feel safe about leaving off the anthracyclines and offering patients the alternative regimens that have been developed over great research over time. And lastly, really looking forward to the new drugs on the horizon, which I think some of my co-panelists tonight are going to bring up, some of the exciting things coming forward that we might be able to incorporate. One of the things that I really want to highlight is the ongoing research happening now with studies like Compass PCR, which is closed to accrual, but we hope to see good results from there, and also the iSpy and other trials, where it looks at really tailoring what we give to the patient in totality of her treatment based on the response over time while she is on treatment. And I say she, but it could be a he. And so really just focusing on a patient-specific tailored response in blocks and chunks of treatment, so that really only those cancers that get some of our most toxic drugs are the ones that demonstrated lack of benefit from the upfront drugs, and therefore we feel that it is warranted and worthwhile in that person's course of treatment to ask them to face those risks of those increased toxicities. So that was a fun event for me this afternoon. What I would say was also incredibly meaningful for me today. One of the things I have focused on in my career is young women's breast cancer, and also defining and identifying what we call postpartum breast cancer. So I study women and the relationship of how their breast cancers behave in terms of whether they had not had a child at the time of their diagnosis, were pregnant, or in particular are young mothers, women who have children under 5 at home at the time of their diagnosis, or even out to under 10 at home, and try and look at comparisons of outcomes and why the biology of these cancers appear to behave differently. And when I started this work 15, 20 years ago, people said, what's young women's breast cancer and postpartum who? And I got back a lot of grant reviews like that. But I was really pleased today for 2 things that just warmed my heart. One of which was, you might not remember, but there was a person who stood up and asked a question about one of their cases to Dr. O'Shaughnessy when she presented her clinical trial today. And she referred to her patient as a postpartum breast cancer patient. So this is a physician from India who is embracing the fact that this is a subset of breast cancer. And then even more important was I had the privilege of presenting a poster with 2 advocates, Ellen, Linda. And so, and this was also in conjunction with my long-standing scientific partner, Pepper Shadeen. And so the opportunity to really come together as a scientific team and try and spread the word about postpartum breast cancer and why we need to be advocating for one very simple thing. All physicians need to ask their patient how old their youngest child was at their diagnosis, And we need to start incorporating this one data point into all of our clinical trials so we can parse out who is benefiting from our advances in treatment and who is not among these cancers that have a higher risk for developing metastasis over time if we don't figure it out. So for me, that was a pretty profound moment today.
Awesome. Great. Andrew?
So there was a lot of great data today. The SABCS is always full of pivotal data, and today we learned not just about immuno-oncology, but a particular drug being used in an earlier setting, and that's tucatinib. And one of the reasons that was really pivotal for me is dealing with patients with brain metastases. We're always looking for additional treatment options for these patients. If you look at patients with metastatic breast cancer, 1 in 3 women will during their lifetime develop brain metastases. So it's a really daunting number. And when you look at HER2 positive breast cancer, it's as high as 1 in 2 women with metastatic breast cancer will develop brain metastases. And then when you look at the timing of that, it can happen relatively early in the course of the disease. So it's something that we are challenged with. The median time to develop brain metastases in a patient who's HER2 positive with metastatic breast cancer is about a year. So we need to do as much as possible for that. There's been a dearth of studies that allow patients who have active brain metastases, in other words, metastases within the brain that have not been previously either resected or treated with radiation that are actively growing. Those patients over the years have typically been excluded from clinical trials because there's a lot of different reasons. There's probably a little bit of nervousness about having to have potentially outcomes that are affected by that and being included and attributed to the drug. There are a number of different reasons, and we want to obviously do what's best for the patient. The HER2 CLIMB study, which is the predecessor to this one, did allow patients with active brain metastases. So let me take a step back. The drug is tucatinib, and what it is it's a small molecule that gets into the HER2 receptor. Everybody's familiar with trastuzumab. It's an antibody. It sticks to the outside of the cell where the HER2 protein goes through the cell wall. But on the inside of the cell is where a lot of the action of the HER2 protein is. It actually puts phosphorus groups onto other proteins and allows that to convey a signal of growth in that cancer cell. And so tucatinib is one of these molecules that gets inside of that part of the protein and prevents it from being able to signal downstream. So what we're trying to do with these, what's called receptor tyrosine kinase inhibitors, is block the inside signaling together with using the antibodies to block the outside and prevent the molecules from being active in a number of different ways. So with the initial HER2 CLIMB study, tucatinib was added to trastuzumab, Herceptin, and Xeloda, capecitabine. And about half of those patients had brain metastases, and what we saw was there was about a 40% response rate in patients with active brain metastases. So, and that was, like I said, a randomized controlled clinical trial. You don't have better evidence than that when it comes to brain metastases. So that was really pivotal. So what was done now with HER2 CLIMB-02 was to try and move this drug earlier in the treatment of patients with HER2 metastatic breast cancer. And in this case, it was adding it to Kadcyla. And the reason for that, one could argue a number of ways. Why wasn't that used with a different drug? But at the time, it was before, and HER2 was actually approved, and Kadcyla was the typical second-line regimen for HER2 metastatic breast cancer. We were using pertuzumab and trastuzumab and a taxane at the first line for metastatic breast cancer, which is HER2 positive, and then it was Kadcyla. Now we have HER2 as an option. So what they said is, let's add tucatinib, Tukysa, to TDM1, Kadcyla, and see if we can make it work earlier in the course of the disease. And in fact, they saw a similar improvement in terms of activity. And in this study, they also included a very significant number of patients with active brain metastases. 40% of the patients that were enrolled on HER2 CLIMB-02 also had brain metastases. Of those, 60% were active brain metastases, and about 30% were untreated brain metastases, so they never received radiation or anything like that. So, so a very challenging population, and it was a positive study. Did improve the time to progression for these patients. It was about a little over 2-month benefit in terms of patients with brain metastases. Now, it benefited all patients, but I think it's really important that we have data specifically in the brain metastases population. And so we're adding to our armamentarium, and we're setting a precedent that it's okay to include patients who have active brain metastases on these trials to offer them something besides radiation when their tumors are growing in the brain. And if their tumors aren't controlled with radiation, we have as many as possible options as possible in terms of systemic therapy.
Thank you. Jenny, what's hot?
Okay, so I was given the straw to talk about immunotherapy. There were like 4 presentations, and the first 3 were in the early breast cancer setting, and 1 in the advanced or metastatic setting. So talking now about early breast cancer, what is IO? What is immunotherapy? Well, simplistically to think about it, what it is, it's basically, the T cells, your immune cells that basically has to recognize the cancer is foreign and that these white cells would come and then eat up the cancer. The problem is that there are these breaks, and these are called immune checkpoints, and they stop your white cells from recognizing it. And what was very interesting was these 3 papers that were presented in the early breast cancer setting. The 2 were positive, and the 2 positive was when these immune checkpoint inhibitors were given when the primary tumor was still present. So it's in a neoadjuvant setting. And the study that was negative was given after the tumor was removed. Overall, very simply, I'm not going to, there's checkpoint and there's the keynote studies, but overall, the pathologic complete response rate with the addition of these immune checkpoints was elevated. It was much more increased. Now, this may not translate into overall survival benefit, and so we're waiting for that data for this ER positive subset, so we don't know yet. It looks promising, but the data, it wasn't a huge difference in PCR, but there was a difference in PCR. Now, weirdly, in the adjuvant setting, after the tumor has been removed, when you give atezo, you can say atezo is less active, maybe not, but the benefit wasn't seen. So there can be a lot of, we have to start thinking about why this may be. Is it because with the primary tumor intact, you are actually educating your white cells to go, oops, that's foreign, we're going to eat it up. That could be a reason. And so there's a lot of work now being done. And I think the take home for this is if you have TNBC, triple negative breast cancer, you need neoadjuvant therapy. Okay, unless it's really, really tiny weeny. You're going to need neoadjuvant therapy, and that is take home. That is, if you're a TNBC and your surgeon tells you to just take out the lump, do a lumpectomy, mastectomy, that's a no-no, because it makes a lot of difference to the treatments we give you, and it makes a lot of treatments after neoadjuvant therapy. So that is a definite take home. But I think we're learning many, many new things, and what is really, really fascinating to now, we can pass out now with the technologies to figure out, what is it that we're doing to the tumor, right? We can look at different subsets, which was kind of done. You can look at TILs, you can look at, many other things like this, the score for these immune checkpoints. We can do all that. But now we also have wonderful, wonderful technology that can actually, with a single slide, look at 40, 50 different antibodies. And we can see the neighborhoods and the tumor cells interacting with it. And so from now, we can begin to figure out why is it some people respond and some do not, right? So that was a very interesting study, and I thought that the early clumping all 3, I know they're not the same, but telling you perhaps in principle, neoadjuvant therapy, definitely for TNBC, maybe for a subset of ER-positive breast cancer. And then the next and those were presented by great presenters. And then very interestingly as well, if you go into the metastatic setting, and Hope Rugo presented this, is we're doing really well with treatments. We don't cure very many people, but we hopefully for a lot of people, we can keep the disease away. But our main purpose is still that you have great quality of life, right? So Hope presented this data where you basically give chemo together with immune checkpoints. You give it for a few cycles. You're responding or stable, and then you randomize to either continuing chemo plus pembro or a PARP inhibitor, which is the pill, and much better tolerated. And the overall results between whether you continue chemo, which is toxic, we all know that, or this pill, the PARP inhibitor, it was the same. Same for PFS, same for OS, and maybe for tumors that had mutated BRCA, maybe it might even be better to use a PARP inhibitor in that setting. So all these things we're beginning to learn in the metastatic setting, in the early breast setting about IO. And I think the take home for TNBC for me is we have to know more. It's too heterogeneous. And I think one of the biggest issues that we are having is that we clump all TNBCs together, but we know there are many, there are like 5, 6 different diseases. Maybe we can make an impact on basals most easily, but then the metaplastics, the mesenchymal types that basically are so chemo non-responsive, they're resistant. And so we've got to find different ways of activating your immune system, make it better, make tumors recognize that as foreign. And we, together with the host, us, the body, as well as the treatments that we have, find ways in which we can multiply attack the cancer. So that's it.
Great, thanks.
Yeah, I mean, so I am a more triple-negative breast cancer or inflammatory breast cancer researcher, or at least had been. And one of the reasons I was doing that is because I felt like so many smart people working in the ER and HER2, they don't need me. When you're looking at the researchers, how they approach tumor tissue, there are two schools of thoughts. One of them is lumpers. They put all of them together, wanting to attack them globally with the immunotherapy, which is wonderful. And then there's a splitter. So you want to clump them into different groups, and they dissect them, all of them. So I'm a splitter. So if you are telling me you're from Texas, I want to say, are you from Dallas? We're in Dallas. Are you from Houston? We're in Houston. Sugarland. So I think that I'm a person, by understanding the individual precision, you could actually do a better, approach for your treatment. So I was always like that. So to me, the ER positive cancer for many years were like, oh yeah, they all respond to CDK4/6, ER, what's the difference? But I think today I've learned by so many different researchers that maybe we are getting out of the era and truly learning there's a different characteristics of the splitting factors of the ER positive disease. And one of them is dear to my heart is the NF1 loss cancer that I actually accidentally got into this by being at Baylor for a number of years with our partners in crime. And I learned that actually the NF1 loss or mutation is very common phenomenon, but nobody paid attention, or maybe people are paying attention, but not in the therapeutic vulnerability era. That this is one of those areas that we are really learning that we could even have a synthetic dependency of very common target of the everybody getting like ribociclib, the Kisqali of the Verzenio of the world, the Ibrance of the world, is inhibiting that specific target. For some reason, if you have this protein is keeping the gate between one of these really important activating pathways and the actual receptor of the estrogen dependent catcher, you could actually release that program and activating this one of this important target of these branches of the brothers. And maybe that creates a more sensitivity of the specific inhibition. Therefore, if you're thinking about what are the patients you wanted to consider, you give this combination in the neoadjuvant preoperative setting, adjuvant setting, maybe in the metastatic setting, then we could actually consider as a potential biomarker. We need to do more study. If they progress on that, supposed to be the best medication, now you really have to go to after the meat, and then you actually have to inhibit the MEK inhibitor. So we have actually a trial that's ongoing. So beyond that, there are so many people now using the circulating tumor DNA, trying to see what are the response assessment in the early to late transition of this estrogen dependent cancer. So to me, that was really great. And then in the same note, all of the CDK4/6 inhibitors started many years back, and now we have the data of the 8-year follow-up from the Monarch 3. And their primary endpoint was what are the duration from your time that you're starting this combination of the medication and then until the time that you say that your cancer is now progressing, so progression-free survival. And then just like any other CDK4/6 inhibitor study, the progression-free survival met its primary endpoint, meaning that the trial proved that their combination actually works better than if you're not taking that CDK4/6 inhibitor. But then the question comes, if you don't have a statistically significant overall survival benefit, how does that, mean? Like, what does that mean for our day-to-day practice tomorrow? So, like, let's say if you go back to your oncologist on Monday, how are you going to interpret data? So I think it's one of those phenomena. It's called debiasing, the statistical myth, that statistics is a tool where we are trying to test our hypothesis, design a trial, and then prove, yes, our drug based on this hypothesis is going to work. But in some way, now we have so many good medications that truly understand this splitter-based precision oncology that maybe whatever happens after you're done with this combination that you're supposed to use in the clinical trial, it is actually very different. And some of the patients who are not receiving the actual medication and then receiving placebo may take the medication after the fact, which could be reversely bias the outcome of the overall survival. So to me, now we are finally at the point we really have to smartly think about, do we really need to look at the OS in every single trial? If we were going to do it, do we need to look into the dynamic therapy regimen? So a lot of statisticians are working on that. So I just wanted to point that out. So.
Great, thanks. And last but not least.
I wanted to try and cover some little nuances of breast cancer in general, because breast cancer I find incredibly difficult, complicated. I don't know how anyone can understand everything that's going on. So I was going to cover three things very briefly, if I may, Beth. DCIS, imaging, and surgical things that we are doing less of. So let's start with the DCIS. There was a beautiful session last night which confirmed that if you have a margin around the DCIS you remove, that pre-invasive trapped in the duct changes of cells, if you have a 2 millimeter margin when you have it excised, then actually your chances of having future problems, allowing for all the other possible treatments, are very low over the next 10 plus years. That made me think about, well, how does it feel to go through surgery? Or, as was mentioned last night and as is happening, there are 4 clinical trials asking the question, could we just monitor the DCIS in place if it's low-risk DCIS? And I would commend to you a poster that's being presented by Deb Collier, patient advocate from San Francisco, tomorrow, in fact, where she and the other advocates have got together to try and look at how do people feel about the concept of not removing the DCIS in her breast, the active monitoring side of things. And I would say definitely go and have a look at that poster. So just as we're thinking about doing less surgery for DCIS, in the armpit, in the axilla, whereas surgeons, we used to take that whole pyramid of axillary tissue out. And then we thought, well, maybe we don't need the top level, the level 3. Maybe we can just take the first 2 levels out. And then some smarter people than me said, let's just sample the lymph nodes, the sentinel lymph node biopsy, which has now become the standard of care for most women who are having axillary surgery. And now heretics from Switzerland, from Chile, and from other countries in Europe have said, well, do we need to do any surgery to the axilla if you have a small estrogen receptor positive breast cancer and axillary ultrasound says there's nothing going on there, published as the SOUND trial? So we heard an update on that last night, the Nautilus study, saying that actually the chances of there being anything wrong in the axilla when you've got a small estrogen receptor positive axilla scan negative armpit is actually not very high. And even if you do have lymph nodes there, the modern treatments that these characters with their drugs offer and the radiation therapy that we use will probably mean that there is no disadvantage if you've got a good risk breast cancer, no disadvantage to leaving the armpit alone. And as those of you who have had axillary armpit surgery know, it's no fun to deal with the scar there and the consequences of whatever you've trying to do with your arm. So I think that's possible progress. So just as surgeons have been de-escalating things over the years, the folks who look at imaging, mammograms, etc., are beginning to think, do we need to do mammograms quite so frequently? I wanted to highlight two studies, one which is being displayed as a poster 1711 right now downstairs, which is saying if you have some changes, what are called atypias, not invasive cancer, not DCIS. Atypias are things that look weird down the microscope when a biopsy is done. Many of us follow those patients much more closely for the next 1, 2, 3, 4, 5 years. But actually, the evidence coming out of the UK says that the risk we've been giving to these people with atypias is not anything like as big as we used to think. Mm-hmm. And so maybe we need to do less aggressive investigation with our mammograms, et cetera, in those patients than we used to. And then I'm going to finish, Beth, by mentioning a study which I can't give you the results for, but it's being presented as an oral presentation in Hall 1, Friday morning, 8:30, 9 o'clock, by Janet Dunn. This is a trial where women who've had breast cancer, had a mastectomy or breast conservation, are over the age of 50, so it's called the Mammo 50 trial. They've gone 3 years with no problems. The question is, beyond that 3 years, should we be doing the annual mammography that we've tended to do historically, or could we make it a mammogram every second year? Is there any disadvantage, or does it make any difference? Now, the fact it's an oral presentation, you can judge for yourself whether it's going to be meaningful or not, and I can't tell you results of that yet, but please go and listen to it, because I hope it will influence how we follow up patients who've had breast cancer treated. Thank you, Beth.
That's great. While we're waiting on people to line up who have questions, do any of the panelists have any comments on what your colleagues have said about these topics?
Maybe I could dive in and just say that I've actually learned a lot just listening to the digests of things that I went to. And I don't think you can repeat too often, certainly to simple surgeons, and distill what's coming out of this, what is now a very complicated disease condition to understand. And it's through me listening to you guys that I'm beginning to learn some of the complicated drug things that are happening, which are good for our patients that need them.
Do we have any questions yet? I need you to step to the microphone, which I can't see, but it's somewhere. Oh, there's this spotlight straight in my eye. Mm-hmm. And remember to state your name and your organization and keep it to one question, not on a personal issue.
Okay. I think I can do that.
Great.
Dr. Thompson, my name's Linda Weatherby. I did the poster with Dr. Borges today, but I'm not going to ask a question about that, actually. On your comments just now about DCIS, I guess I do want to ask a question, but I guess I want to frame it as a reflection. Like, could we start from a patient plea perspective when we talk about DCIS to kind of talk about it with some bookends? Because everything that's out there right now is that there's a concern about overtreatment of DCIS, and I understand that. But the other side of it is for patients who do recur with DCIS, they don't seem to recur with early stage. They seem to recur as metastatic. And so whatever percentage that is, I know it's low, but I would love for the profession to acknowledge that that's happening. And for some reason, they go all the way to Mets. And there's more than a few people in this room who that's happened to. And I think we all go into advocacy because we're like, what the hell just happened? Yeah. I was stage 0. So I just wondered if you could comment on that and then maybe put a movement forward to say, yes, overtreatment, we don't want to do that. However, we need to address what is happening on the other side here.
That's a brilliant set of points, and I agree with you. So let's not consider DCIS as a single problem. There's a spectrum of those for whom active monitoring may be all they ever need. But there's also those who have more aggressive DCIS, maybe more extensive, maybe higher grade, maybe planning to do nasty things in the future that we do not want to undertreat. And our communal problem at the moment is we do not understand enough about DCIS. So there have been folks looking in more detail in the laboratory who've been finding some of those DCIS as you described that actually go on to do something more, either in the breast or elsewhere in the body, they have some peculiar derangements to them, which may start to be the targets that the sort of NF1 issue that you were mentioning earlier, some of the other targets, some of them have HER2, that we may be able to be more thoughtful about how to distill out the bad characters and focus on them while not over-treating those who do not need such necessary treatment. So thank you for your question.
Next.
Hi, my name is Bianca. I'm with the Breasties nonprofit. And Ginger, I'm just wondering, for people who have triple positive breast cancer or any hormone positive breast cancer, does that make them more susceptible to a reoccurrence in the future if they choose to get pregnant?
So when we think about the interaction between pregnancy and breast cancer, it's super important to think about what that woman's life history looked like at the time of her diagnosis, which is different than what we know women can choose to safely do after they've been treated for breast cancer and are remaining healthy. So my comments earlier about postpartum breast cancer really reflects to the woman's status as having given birth to a child or not at the time of her diagnosis. Now, we have many women who come to us diagnosed with breast cancer, either before they had the opportunity to have the family they desired or not done yet. And so through some great work, both in retrospective series, which a lot of which came out of Europe, our colleagues there, Dr. Amant, who is an OBGYN who has a huge series on this and has published it with his colleague, Hetep Hazim. And of course, globally, there was a big clinical trial run called the POSITIVE trial led by Ann Partridge from this country. So that's a different question. That is if a woman has an estrogen receptor positive breast cancer, HER2 either way, and she'd like to have a child, what is the safety of putting a pause on her endocrine therapy so that before her biologic clock of fertility gets to the point where being able to have that pregnancy and move forward becomes a problem, can occur, and then that person resumes their anti-endocrine therapy and continues on. So the POSITIVE trial was initially presented at this meeting last year, and it showed us that in that study, women were asked to be on their endocrine therapy for at least 18 months. But if they were between 18 and 36 months, they were then given the opportunity to hit the pause button for 2 years. They could go forward and become pregnant by any means they wanted, naturally using reproductive assisted technologies. And many of these women had had the opportunity to afford themselves of oncofertility, so some egg or embryo banking before they even started their breast cancer treatment, which not all women have access to. And the women who then had children and went back on their endocrine therapy in follow-up so far, albeit short length of time, there is no difference seen in how well those women are remaining in comparison to 2 very large clinical trials done in the same population of patients called the SOFT and TEXT studies. So it gives us reassurance that we can talk to our women who are in this situation at the time of their diagnosis, offer them things like oncofertility. We also see great work from Matteo Lambertini and also US oncologists who have used those shots doctors put women on to shut down their ovaries as part of endocrine therapy, so drugs like Lupron or Zoladex. If we employ them right before, the week before the start of the chemotherapy and put the ovaries to rest, it can actually enhance the ovaries remaining well and that woman having a higher level of fertility and greater success of being able to have a child afterwards. But I want to really impart to this audience, because it's a really important aspect of this conversation between the treating doc and the patient. If that woman has remaining breast tissue, you have to have a conversation about lactation before she has that child, because I'm a huge supporter of lactation, and I know many women choose to do it for a very long time. But when we are talking about women who are interrupting important therapy to have a child, unfortunately, we have to ask them to truncate that so we can get them back on treatment. Otherwise, they're not on treatment, and we don't know that they will remain as well. So did that answer your question? There will also be follow-up data from the positive trial presented later at this meeting. Can't tell you the results, but please look for the presentation.
And come to Hot Topics tomorrow and Friday night.
Hi, Kelly Shanahan, Board of Directors of Medivivor, which raises money to fund metastatic breast cancer-specific research. I have a question for Dr. Borges. Given your findings about the increased incidence of metastases when breast cancer is diagnosed in the postpartum period, what do you think future directions may be in terms of surveillance, whether it's increased frequency of clinical evaluation, which will also need to involve OBGYNs, which you've got one on your team, an advocate, but also whether considering any future work looking at biomarkers, CTC, ctDNA, et cetera.
Yes, thank you. Those are great questions. And thank you for the funding from your organization, because you do fund our work at the University of Colorado in this space. So how could we do surveillance for women who have had a child and are at increased risk of postpartum breast cancer? That's a question for which I don't currently have an answer. We know that these are young women who are typically below the threshold of recommended screenings, and I'd love to hear from my colleagues on the committee if they have great ideas, imaging, and how to do it at an increased frequency to find this when there are, in the US alone, somewhere between 4 and 6 million women having a child each year, depending on pandemic-related changes to those numbers. And when you look at the 27,000 women or so who get diagnosed with breast cancer under 45, it is 13,000 of them who will fit this category of a postpartum breast cancer. So it's a huge denominator to find a very important numerator. And I don't know that I want to encourage women to start rushing out and doing tests that are fraught with false positives and other conundrums. I think some of the newer technologies, like you mentioned, the ctDNA, and the opportunity to find a breast cancer before it is even clinically apparent are intriguing and exciting. But we don't even know how to apply that in cancer in general, let alone, again, to this big numerator-denominator issue. So keep funding us and we will keep working on it.
Thank you all so much. My name's Tracy Cushing. I'm the chair of the Lobular Breast Cancer Alliance Board of Directors. So, of course, I have to ask about lobular breast cancer. General question for the panel, 2 questions. Did you learn anything today that was a hot topic in lobular breast cancer that you could share with us? And number 2, we learned in the educational session yesterday that at autopsy, 40% of lobular breast cancers were undetectable by standard imaging. How are we going to address that? Thank you.
I can try and take some of it. Yeah, I mean, it is. I mean, lobular breast cancers are the most difficult to diagnose by imaging, and I think the current best is clinical exam and MRs. It is a different disease altogether. I think the biology is completely different with the loss of e-cadherin. So the tumors basically present at a later stage. I think we're learning about new mutations. I think there is a rare HER2 mutated lobular cancers that may respond to certain tyrosine kinase inhibitors. Studies are ongoing, led by Dr. Kennedy, I can't remember, and Carlos Arteaga's group. But there are interesting studies. We're beginning to understand that this is not just one disease, and the biology of lobular cancers versus IDCs is, it's vastly different. And we do need better imaging. I mean, I do not know whether contrast-enhanced mammography it picks up lobulars better. If anybody knows the answer, I don't know the answer. Do you know the answer?
So actually, 2 aspects of it is like, first of all, the biology that we are learning more about the lobular, I think the E-cadherin is one of those like important key. The E-cadherin is kind of like the junction protein that we're gonna hold our hands together to stay together. But we lost this protein, and now you're free to like inject, and they like move like we used to call it pile appearance. So they like inject like branches. So
Correct.
even though my patient has a seeding of the whole bowels or stomach filled with the cancer, a lot of times that imaging cannot show because they're small and surviving. Very similar behavior that inflammatory breast cancer can do. So we're actually trying to do the comparison study using some similar models that we have learned from more well-known to be more aggressive kind of cancer. And we think that actually this metastatic pattern by itself might be a target that we can actually change the course of the nature. And then the other thing is, there's a new PET scan, that's supposed to like detect estrogen. My patient had to pay like $18,000 and she passed away and all these things. And so it is a moving progress. So far, I am not too convinced that it is actually the ultimate answer. But I think there is actually moving towards hopefully the right direction. I think the other thing that we're trying to do with the lobular carcinoma is not only understanding the actual tumor itself, but understand the interaction with how the lymph node gatekeeping could be different in those cancers. Because in my patients going into thinking that they're stage 1, come out with the 7 lymph node that is positive with the lobular, and so it happens too often. So it is a moving progress. I think it's a learning progress, but I think we have made so much more progress compared to even 3 years ago.
Yep.
Anyone else have a addition to that?
No. What about mammography is obviously crap, but what about
The metabolic, yeah, so there is actually the metabolic detection mammogram that people are developing, but because of the lobular carcinoma is supposed to be metabolic cold, we don't know if it's going to add the value at this point, so.
Hi, my name is Jill Canales, and I am here on behalf of Memorial Care Cancer Institute and the Pink Journey Foundation. And my question really is probably mostly for Dr. Ginger. I know. But I think that there's a lot of interest and concern in the community about young women and breast cancer. I work in a breast oncology center where we're seeing younger and younger patients all the time. And I'm wondering, number one, how long have you been focused on what your term postpartum breast cancer is? Has this been going on for years? And are you seeing younger women? And number two, the concern around, the medical community wanting to do less and fewer, more time between imaging, but yet we have this subset of patients that have aggressive cancers, have high mortality rates compared to older population, and yet we're talking about the possibility of doing less imaging, not more, and that kind of tug between why is there so much young breast cancer and what do we do about it?
So in order of what you asked me, I've been focused on young women's breast cancer since 2003, and we started the Young Women's Breast Cancer Translational Program in Colorado in 2004. We landed on the concept of postpartum breast cancer and first published it in 2009 and have been working on it ever since. And this is not a solo journey. So I have done this work largely in collaboration with Dr. Pepper Shadeen, who is now at OHSU in Oregon, and with Dr. Tracy Lyons, who is with me at the University of Colorado, and many, many other people and collaborators. I happen to see a lot of young women's breast cancer, but we all do. And so I think everyone on this panel can speak to this topic. There is increasing incidence of young women's breast cancer seen worldwide, particularly in countries around the globe where access to healthcare and access to treatment is often the most limited. So I emphasize this is a disease of global disparity. In the United States and other countries, it's also been defined that postpartum breast cancer is increasing because, and I include myself in this statement, we as women are making different choices. If we are choosing to have children, we are choosing to have children often at older ages. And Mats Lamba, years ago, he's a PhD researcher from Sweden, had a New England Journal paper that highlighted that women who were in their years postpartum have an increased risk of developing breast cancer. Now that's different than what we usually think of. We usually think of having children and nursing our children as protective against breast cancer. And it is, if you don't get diagnosed in that first 10 years or so and you have your children young, there is this crossover effect which protects us over here when we're older. But there are women who get diagnosed in those years. And if you're like me and have your children at a later age, the MD thing, I have a permanently increased risk of breast cancer unless I live to past 80, 85 years of age. On balance, having kids is protective against breast cancer in the US because most diagnoses occur over here in those post-menopausal years. But there's this subset that are at increased risk. So I'd want to open this up to others because, like I said, we all see young women's breast cancer. What are you guys seeing?
Yeah, I think it's increasing. I mean, globally it's increasing. I think that the lifestyle choices, as you rightly say. Pepper had some data on prolactin as well, right? I can't remember. She showed some really great data. So your hormone levels fluctuate quite a lot, and that has a lot to do, again, with breast cancer incidence and initiation. Do you remember?
Right. So exactly what causes the initiation, there's many possible hypotheses of things that are happening during pregnancy and changes within the breast. What we know about postpartum breast cancer, I think, is a little bit more secure, which is the natural part of when a breast undergoes involution, which is a fancy medical term for weaning, which happens if a woman has a child and does not nurse or when she ceases nursing. Those natural processes look a lot like a wound trying to heal, and wound healing is something that promotes how cancers can behave. So it's a little bit of fuel to things like increased in the capacity of the tumor to grow, to invade, and to metastasize. And in animal models, we've worked out that it has to do with issues related to collagen and immune cell influxes and inflammation, and also an increase in lymphatic channels, which translates to when we see young women diagnosed with these cancers, they have increased lymph node involvement. So those are, but why exactly the initiation happens, I don't know that we have as much.
Yeah, I mean,
knowledge.
so one of the things that could hypothesis is so all of us are included in the single cell study. So now we are at the point where we're doing the biopsy, where they actually get the donation from our patients, and we are looking at every single cells in the breast. So Alistair has done that in the DCIS. I have done that in the normal breast tissue. So I think that we have a hypothesis that what might be happening is that in melanoma, skin cancer, you biopsy your skin of the young baby, 10-year-old, 20-year-old, 30-year-old, you have started to have an accumulation of the mutations in your normal skin cells. So we actually think that same thing may happen in the breast tissue. So let's say I had my baby when I was 43. So by 43, compared to 23 years old woman, my breast cell already had an inherited mutation that's accumulated. And now the cancers are, the cells are expanding by the surge of the hormone, and then you have to go through this natural course of increasing and then have the involution. And during the process of it, the same pressure could actually trigger the higher threshold of the mutations, which we might explain at least some of these younger women postpartum phenomenon. So it's one of those things that we are trying to study.
I am going to ask, because we're getting a nice backup of questions. It's very tempting, given how incredible our panel is, to ask them about questions on general research they're doing. Let's try to keep the questions focused on what's happened at the symposium yesterday and today, because I think that will help more people who are interested in what they heard and saw today and yesterday. So, next question.
Hi, I think I can do that. That's right. Wow.
Good.
Okay. Hi, everyone. I'm also short. I'm Maida Sutliff. I'm with the Metastatic Breast Cancer Alliance. Thank you to the panel, to the Alamo Foundation. Hot Topics is also my favorite time of this week. I've learned so much over the years. So I'm going to change the subject, and I'd like to direct this first to Dr. Brenner. 2 words, brain mets. For anybody, myself included, that's been diagnosed with breast cancer, it's horrifying, very scary to think about brain metastasis. But it's very interesting. There's a shadow and a veil talking about this. It's not easy to talk about. So we can talk about the session today. There was a session putting the spotlight on brain metastasis, but I'd also like to see if you could address surveillance and screening with brain metastasis, because I don't understand why we're not changing the guidelines, and it's not a rare thing when you look at pan-cancer, lung, melanoma, the big four cancers, breast, I think it's kidney or something like that. So anyway, if you could talk for a few minutes on that. Thank you.
That's a great question, actually. And the guidelines probably are going to be changing. It probably won't be in too long. So the reason that they haven't changed is because there have been studies looking at doing surveillance where you take women who are at high risk and you do MRIs or you don't do MRIs. And there's, in terms of differences, in terms of measurable outcomes, like do they live longer or do they live better? Okay, those studies, there was one, for example, it was done in 2011, randomized patients at high risk. They got MRIs. One group was detected earlier than the other group, but there was no difference in terms of outcomes. And we have a reluctance to do imaging just for the sake of finding something if it's not going to change how well a patient does, right? We don't want to just jump on treatment if we're not going to make them necessarily live longer or live better. And so things have changed a lot in the last 10 to 12 years. We just talked about just one example with HER2-CLIMB and HER2-CLIMB-02, that we have CNS active regimens. So if you can detect things at a smaller stage, maybe you don't have to rush to SRS. Maybe you can just choose your active systemic regimen. And there actually is a study ongoing right now. I have patients that I've actually had to refer, because we're not participating site, that we referred up to New York to have them participate in these studies that are being done at Dana-Farber. But I think that will be changing within the next couple of years, because now we have something that we can actually do about it besides just say, yes, you have this problem and shoot them off to radiation.
Alistair, were you going to add anything to that?
I was just thinking that more generally, the science is ahead of what we can do for our patients in terms of before metastasis, picking up what's going on. And I was thinking about the cell-free DNA discussions that were going on earlier today, where we can pick up stuff in the blood, and and there are several different tests out there, and there are several different stuffs that we can pick up in the blood. But at the moment, we're not either clever enough or able to target adequately some of the things we're finding to have as much impact as I hope we will one day have on the patients that have some of this overspill from DCIS, invasive cancer, cancer elsewhere in the body.
Let me ask the panelists also, I went to the poster spotlight session on enhanced imaging techniques, and I don't know if anyone else did, but do any of you have any comments about the conclusions that were drawn from that? You can say it a lot better than I can.
Well, I'm a fan of imaging, but again, imaging is several steps ahead of, first of all, understanding how we can apply it more generally. There's lots of fancy places, including in Houston, that are doing really smart imaging. But we could probably do better with what we have. Things like contrast-enhanced mammography probably has a much bigger role to play than we are using in the United States. The Australians and the Dutch are leading this gangbusters.
I wanted to say something about these pan-cancers, predictors of eventual brain metastases. The data is there. I think over the next few years, you will be able, from your primary cancer, select the cohort of patients that are likely to have 40-50% chance of brain metastases. And then that's the big question. Do you image them? Do you give them treatments with brain penetrant treatments? And I think the answer is yes and yes. And those studies are coming out. And we're there. We have the data. It's just passing it out at the moment.
And if I could just contribute one comment. So one of the really encouraging aspects of the fact that the HER2-CLIMB-02 trial did show the improvement with the addition of the tucatinib is that for someone who is newly going through their treatment for a HER2-positive breast cancer, Right now, if they undergo their neoadjuvant treatment and do not get that complete response that we're looking for in the breast and the lymph nodes, there is a nationwide accruing randomized clinical trial called COMPASS RD, so stands for residual disease, and that is building on the backbone of the success of the earlier Catherine trial, which taught us that if we give TDM1, which is one of those antibody drug conjugates of trastuzumab linked with a chemo, in place of just continuing the trastuzumab, we improved the cure rates of women. And so now the study, COMPASS RD, is literally the HER2-CLIMB O2 regimen brought forward into the adjuvant setting with the hope, beyond just improving the cure rates for those women, that if we employ tucatinib in the early breast cancer setting, maybe we won't see this 50% risk of brain mets in the setting of metastatic disease or in the first year of metastatic disease, or at least less.
Yeah.
So if you know anyone facing that decision today, I think we all give that study 2 thumbs up.
Yeah.
Yeah.
Then while cell-free DNA or the circulating tumor DNA are not at the point that we could actually use the data to pick a choice of therapy today, what we can potentially use is that just like any other, the blood cancers, we are now at the time that maybe we can even aim for the molecular remission. So even though we can't really say that we're going to use this to give you a new drug, but we could confirm whatever we offer you as additional treatment today could potentially really save you from for someone who's going to have a recurrence in from 2 years versus who actually you are able to clear all of your trace of the tumor. Therefore, we actually made a difference for you. So I think there's a different usage we can actually use that.
Next question.
Hi, my name is Melanie Sisk. I'm a metastatic breast cancer patient advocate. I apologize in advance for this question, but I'm curious, when you stage breast cancer, you stage based on the size of the tumor, so you'll have a staging for your imaging, but then when the pathology comes back, what about patients who have multifocal tumors? Then that changes their stage because you just look at the size of the largest tumor. Has there been any studies or is there any correlation between multifocal cancers and the behavior of the cancers or the prognosis of the patient that you know of?
Yeah, I mean, there's no well-done prospective studies because, a lot of time, despite having the best imaging out there, whatever actually end up happening is we have this fantastic MRI. We have 6 different spots that's lighting up. Are we going to put a needle on every single spot of those 6 lesions? So there are some inherent challenges that the new imaging is actually bringing up. So let's say we actually take you to surgery and then we have the outcome at the point. A lot of times what ends up happening is the surgery is already happening. We may not have an opportunity to have an intervention. So a lot of what we are learning for our cancer at this time is we do initial diagnosis, we have an intervention, and then we're trying to see if we can actually save you in the long-term outcome. So that is very challenging for us to prospectively, going forward and studying the difference. But in general, we know if you have especially in the different bloodstream supplies of the cancers, and especially they could be a different cancer, it could be TNBC in one spot and then HER2 positive in a spot, it is challenging. So we know they're behaving worse in general.
Okay, we have a question online, actually from a member of our Alamo Advocate Program Committee, Bob Ritter. The scientific advances are remarkable and encouraging, but how can a community oncologist who treat all kinds of cancer keep up with all of those advances? Would someone like to take that? I think that's a great question.
I think it's challenging to keep up with the advances for those of us who purely focus on breast cancer.
Yes.
And I don't envy the community oncologists who have that wide range of problems to deal with. There are some aids to helping folks out there and a number of guidelines which are there to support decision-making between patients and clinicians of all sorts can be useful. And, we could name ASCO, we could name NCCN, et cetera, et cetera, et cetera. But it's a really tough task for those in the community treat multiple disease problems to begin to distill some of the details that I think we find challenging as breast cancer docs into sorting the patient's problems out for them.
Yeah, I can add to that a little bit. Being both academic and in a community oncology program, I think there are a lot of tools available for our colleagues out in the community. We've done, I think, a much better job over the years now that we have Best of ASCO and Best of SABCS. There are a lot of summary presentations that are out there in the community for our community physicians where they can get all of ASCO and all of SABCS in a single day. On top of that, IT has really moved along very well. So a lot of our colleagues, when they are entering information into the electronic medical record, will get a distilled recommendation that is based entirely on NCCN guidelines and what is established in the literature. So they're not totally on their own, having to know every little detail about everything. There is a bit of both IT and community outreach from all these meetings that really does a good job of keeping your community doctors involved.
And then there's one other comment I might make if I could, and that's for those who are advocates, supporting a patient who has a diagnosis of breast cancer to perhaps seek a second opinion from somewhere different. They may end up having their treatment back home away from the major cancer centers, but to be able to tap into the knowledge can be quite helpful.
We're less than 6 minutes away from the end, so probably we'll only have 2 more questions, but go ahead with the next one.
Okay. This is for Dr. Lim. I was really intrigued by your talking about tools that we can leverage from the translational world, from the bench to the clinic, and especially in the I'm from the MBC Alliance, in the face of such a dire diagnosis like triple negative breast cancer without otherwise having targets. And so I was curious, maybe it's like if you had money dropping from the sky, or if you could at least speak to, besides a clinical trial, do you think there are any tools, and what would they be, from the bench that could be used to tease out the subtypes of triple negative and better target more precision care?
Yeah, thank you for a wonderful question. So I think one approach that we were trying to make was trying to have a, the actual subgroups, they're dividing into maybe 4 to 6 different subtypes of TNBC. We were relying on that. I think that was the best we could do with the technology that we had back in 2011. But now we came to the point that truly we are able to dissect one individual cancers literally in each single cell, not only in the tumor by itself, but the immune cell, they're interacting and being educated with each other, like we are educating each other. I think the tumor cell and then the environments are doing the same thing. So I actually believe that learning from patients is the best. So where does the bench come from in this kind of environment? Now we're at the point that we could actually take the tissue from the patient and we can safely recreate that, implant it into our animal model. We're not even having to sacrifice the animal, but we actually can have something we call organoids that we can actually put it in the petri dish, and then we can actually recapitulate what could potentially happen with the surrounding immune cell in the different chamber, and then test them. Of course, I'm not saying it's perfect, but I think it's one of the good ways that we have improved for the last few years, and I'm sure Dr. Chen can speak more about that.
Yeah, I was going to basically add a little bit to that, especially for the heterogeneity of TNBCs. I have to do a little pitch. So there are, it's divided into probably, I know there are 5 or 6, but there are really probably 3 major target buckets. There's the basals that basically responds best to DNA repair agents and chemotherapy. The LARs, which is the androgen receptor, frankly, we don't know what to do very much. And then the mesenchymal subtype, or the metaplastic breast cancer. And we have a clinical study, actually, in Anderson as well, on a very rare target for this metaplastic rare subtype of breast cancer. It's usually resistant to most chemotherapies and probably immunotherapy. But we have a target with inducible nitric oxide together with a PI3 kinase. This was actually original work that was done with Stacy Mulder when she was back in MD Anderson. And we actually have a large U01, and the clinical study is actually being run out of MD Anderson as well as in Houston Methodist. I think these are new insights because, it's the microenvironment. Very much is what Bora was saying. it's not just the tumor, but what you're hearing from all of us is it's not just the tumor, it's how the tumor interacts with the tumor microenvironment. And we have tools to be able to modulate the tumor microenvironment to enable your white cells to go in and kill the cancer. So we're getting there, we're getting to know a lot more. We have wonderful preclinical tools, PDX models, patient-derived xenografts, but now patient-derived organoids, taking little bits of your tumor and growing it in little lumps that look like breast cancer. And we can put drugs in it and we can understand what drives it. So a little pitch for metaplastic breast cancer, only because it's a very difficult to recruit study because it's rare, but we have an NCI-funded clinical trial.
And we're almost down to the end, so I'm going to wrap it up. And I may have one question. I'll look and see if I have 30 seconds left. Thank you again for attending. Please fill out your evaluation forms. Either do it with the hard copy or do it online. This is important for us because it helps us not only convince our sponsors that we're doing something that's beneficial, but it also helps us improve the program next year. Thank you very much to our panelists for coming tonight and giving us such great information. Thank you to our volunteers who've done so much to put this program together. And very importantly, thank you so much to our sponsors. And I'll just plug one last thing. I predict that 5 years from now, there will be another debate on whether anthracyclines should continue to be given. I've concluded that
Set your clock.
You can
Set your
always
clock.
get approval to add something, but nothing can ever be taken away. So with that, I want to thank everyone. Thank you very much tonight.